Good morning, everyone. Welcome to the 2022 TPA ODP conference. That's a lot of acronyms. We're really excited for everybody who's joined us at the RLA and those who are joining us here in the Zoom room. My name is Craig Douglas, and I am here to provide support to the team today as we work through our conference. So I just want to welcome everybody. And just a couple of quick housekeeping notes as we get started. We are recording today's session, so if anybody gets bounced off for any reason or you have to disconnect, please send a message to information@provideralliance.org and we'll make sure to get you a link to the recorded session for the day. We also will be using the chat and the Q&A for the virtual participants to ask questions and to share comments. And with that, I will turn it over to Patrick to get us started. Patrick?
Thank you, Craig. Welcome, everybody. It's a pleasure to see everybody here in person. I certainly want to thank Kristen and all of the staff from ODP who have come out here today, made the journey to make this conference such a success and to give us so much great content. So, Craig, I'll just let you advance the slides. So what we do have is a program that hopefully everybody should have received. I know folks in the room, we have copies for you to look through. So we look forward to having you participate in the sessions. If you are participating remotely today, Craig will manage everything. If you have questions through the Q&A, he will chime in and interrupt us so that we know that you're out there and have a question. You're welcome to have us open your mic, ask your question directly. If you are here with us live today, we have a stationary mic in the center aisle. We ask you to come up to the mic, and once we see you up there, hopefully we'll notice you and we will acknowledge your question at that time. We do encourage everybody to come on up and express your viewpoints, ask your questions. I know a big part of why Kristen and ODP like to come out is to engage with members and hear from you directly. So it's a dialogue that we very much appreciate at TPA. So we encourage and welcome you to do that. So without any further delay, I want to thank again and welcome Kristen to our conference today. Thanks for making this happen for us, and we're glad you're here.
We are very glad to be here as well. Is this good in terms of volume for everyone? Okay. And I was going to introduce the team, but for folks who are remote, you're not going to see them, and you will see them later when we do the smaller sessions. So I think we'll save the introductions for then. But I do have a comment, Patrick, just about the whole setup here, which is we make a pretty good Pottery Barn commercial right now. And we did not coordinate color palette for our outfits.
No.
So
Who would believe we didn't do that?
Yeah, we really didn't. We did not text each other this morning about outfits. Very impressive.
It is. It is. I will add too, Mark here from the RLA really made this all happen like at the last second too, in terms of our setup. And he didn't coordinate our fashion, but you know, he made it look good for us.
Well, you anticipated our fashion choice as well.
Yeah, he did.
All right. Well, let me start with a budget update. And I know there's breakouts later, and you'll get a chance to hear from Rick a little bit more about budget. But I'll give some of the highlights from the budget that was passed on whatever that was, the 5th or so of this month. Couple of big highlights. One, really everything that was in the governor's budget for ODP was passed through appropriations. So for us, that's there are a couple of important initiatives in there. One is the waiting list initiative. So there is an initiative for 732 individuals coming off of the emergency list for the community living waiver, 100 unanticipated emergencies for the consolidated waiver. So that's same as we got last year. Obviously, we would have been much happy to see a larger waiting list, but we were pleased that there was a waiting list initiative in there. Another, obviously, the rate increases are also in the budget, which we anticipated. That was all negotiated in advance when the rates were published. The other piece that's in there was we have additional capacity to do those transition to independent living and supported living from residential services. Hopefully you have all seen that incentive that we put forward and the rates that go with that. That came out of work with, we did work with a group of providers pre-pandemic, probably, early 2019, about what we could do to better promote the life sharing model, what we could do to better promote supported living. And one of the things that was suggested from that work group was some way to financially incentivize people moving from residential habilitation to either of those two models. So we're really pleased with that for a few reasons. One, because I think it'll help us in terms of this initiative to keep expanding life sharing and supported living. But two, it gives us a nice model with CMS. We worked closely with CMS. This is unusual, an incentive, something that's really kind of built in as an incentive payment within our waiver structure is pretty new. So what that gives us is a nice model to be thinking about other ways that we can incorporate that. So we were very pleased that we finally got that through CMS in June, but we have funding for it in last year's budget and this year's budget. So I think we have no trouble with any number of those that are going to be coming our way to do. One of the other things I'll point out from the budget that was a really nice thing to see was there is a fund. This came out of the Human Services Code. There's a new fund called the Home and Community-Based Services Augmentation Fund. And there has been, as we announced the closure of the state centers, there's always been this question of, well, will the savings actually go back into ODP's system, or will the savings just go back to general fund? And this new augmentation fund says it's coming back to our system, that any savings from the closure of the centers will come back to our system. And just for kind of scope of what we're talking about, Polk's budget right now is about 74 million a year. Whitehaven's is 44. I'm looking at Rick. I'm in the ballpark of those numbers. So not insignificant at all in terms of savings from the closures. The augmentation fund specifically says the calculation for the fund is pretty simple. Whatever year over year is the difference in appropriation in the budget that's passed, that amount of savings will go into that augmentation fund. Also, and this was another piece, other states have done this, but this is a first for Pennsylvania, is the sale of any property, which wouldn't usually come to DHS. That would usually stay within the Department of General Services. Those properties don't belong to our department necessarily. So any proceeds from property sales will also go into that fund. And that fund can be used for three things: DSP quality initiatives, waiting list, and housing for people with disabilities. So, really, really nice way, I think, of helping make sure not only that funding comes back to our system, but also hits on some of those key initiative areas for us. So we're pleased, and that will, the priorities for that funding will also have stakeholder input through Isaac. The language in the statute itself references that Isaac will make the recommendations for the prioritization of that funding. So that was great news coming from the budget. I think those are probably some of the highlights. I mean, some of the other things that aren't ODP, but certainly impact us and impact human services. There were a number of legislative initiatives worked through with the governor's office around supporting nursing facilities. So if you've been kind of watching some of the regulatory movement around nursing facilities, there were some new regulations published that have new higher staffing ratio requirements for nursing facilities. We know from research that more time per patient resident in a nursing facility is going to result in higher quality of care. So those were pretty controversial because, like our system, obviously the long-term services support system is also having a massive workforce issue. So facilities very concerned not only about how on earth they're going to pay for this, but where they're going to be finding staff to meet these new requirements. So not uncontroversial at all. But there is quite a bit of funding in the budget that was passed to try to help the nursing facilities better recruit and retain staff. So rate changes and changes in some of the recruitment retention kind of work that we did previously. So I think those are probably the big highlights. Oh, prudent pay. Yes, it does. The budget does assume that we will continue with the pause on prudent pay through the end of this fiscal year. That is an assumption that is built into the budget. That is obviously a policy decision, but the budget, the way it's written, certainly supports that. And I know that there's a bill that passed, I think unanimously, maybe there was one, well, I think it was 198 to 0, if I recall, through the House. So at this point, the state Senate will be, I don't know if they're going to take that up or not. I know Bill, I saw Bill come in and he may know if there is a plan for that. But at this point, at least the budget certainly supports the continuation of the current policies related to prudent pay. All right. So I guess unless you have questions, I mean, I can stop. I'm going to move on from budget.
Yeah, thanks, Kristen. The only thing I would like to really call out and maybe ask a couple questions about is the augmentation fund. So likewise, I would like to emphasize as well that that feels like a big win to keep that money in the community IDA system. So if I can relate it to TPA's advocacy and what we were working on across the state with other associations, we were sort of on a secondary basis pointing to the state dollars that are associated with that. So I think there's $132 million state dollars, all centers right now. So compared to 65 million, which had been our ask at the time for fee schedule rates. Just to give some context, I mean, it's good to hear that money will stay in. We know that the scheduled closures of Polk and Whitehaven, I don't think it was quite half that amount of money, but it was pretty close to the amount of money that we were seeking in our advocacy. So it's good to have that conversation. Hopefully you and the department can consider savings going to rates. And I don't know if it's too early to talk about whether the net savings from just services. Obviously the per diems are very high at the centers because the census is very low, but $132 million is a lot of money in the centers as well. So hopefully there is some net savings that's fairly significant that we can talk about investing into the community system through rates to support DSPs.
Yeah, well, and interestingly, the way the statute is written, it's just the change in the line item. So it isn't accounting for the fact that obviously the individuals still require support. And so there is still funding associated with that. It's not doing that calculation. That's always the calculation that we have shared just in terms of savings. We have calculated, average of about, $170,000 to $280,000 per person. Community side, I forget, 190 for ICF. We took the average and sort of anticipated from the Hamburg closure, how many people went to a different center, how many went to private ICF, how many went to community. And that's how we had been calculating that projected savings. That's not how the language in the bill is written, which is great for us. I also assume it's a one-time to put into that funds. I didn't read that, but I am not an attorney. I did not read that as that would then be funded each year.
Yeah.
I mean, that would be great. We could figure out what to do with that, I think.
Yeah, that's what I wanted to ask you, because when you say statute, is it a one-time this year budget appropriation, or does statute?
There's no appropriation.
Okay.
It's language that says, and so, and this year there will be nothing, because the language is that whatever the state center line appropriation, the change year to year is, that amount of fund will go into the augmentation fund.
Okay.
So yeah, I read that as one time. Again, I'm not an attorney, but I read that as that one-time savings will go into that fund. So yeah, I think initiatives that require ongoing funding, I don't think that's probably going to be what that fund can be used for. But again, we'll see if there is any further instruction on it.
Okay.
Yeah.
But ongoing initiatives, the state centers have been ongoing initiatives for a long time. So that's been appropriated year after year for decades.
Well, you can certainly make this argument to the budget office for the legislative interpretation.
Okay, we'll do that. Thanks.
Yeah.
Thanks for the tip.
Yeah.
Other questions, or did you have anything else you wanted to wrap up on budget?
That's all I've got, but I'm happy
Okay.
to take questions before I move on.
Bill, did you have anything on prudent pay?
There's no update.
No.
Anybody here in the audience that has a treasure or calling or knows anybody that's on the Senate Health and Human Services Committee, please reach out to them and ask them to push for House Bill 2530 to exempt ODP funded providers from any kind of reinstatement of free pay. It's about a little less than 6% of our annual revenues. It's a one-time hit. So if your revenues times 6%, that's basically what the clawback will be if free pay is implemented over a 21-day period. It doesn't matter because you're going to lose 6% of your AR. It passed 198 to 0 out of the House. So we're hoping the Senate will also, the Health and Human Services Committee has to pass it. So the full Senate will vote on it, and then it'll go to the governor for signing.
Thanks, Bill. And for anybody online, I don't know if you could hear 6% clawback, basically 198 to 0 vote. And Bill, thanks for the advocacy. Others, apologies if I'm missing. Likewise, I know Steve at Achieva, Nancy Ark of Greater Pittsburgh in terms of the language around state centers, obviously waiting list initiatives. So we need everybody's help and contributions. So I will just take a brief moment, Kristen, and mention that Ruth Siegfried, this is not the forum today to really get into a lot of the advocacy, but Ruth has called an advocacy and policy forum, a meeting, a conference that she's going to host, and she is inviting CEOs from across the state. If you haven't yet heard of it or received an invitation, contact Ruth or contact us at TPA. She would like to meet with as many folks as possible next week to really talk about these kinds of issues, what we need to work on, how we can become more unified as an IDA community and coalition to really speak with one unified voice in terms of our communications of the things that we need. So this is a great example of that, and some of what can be achieved as well when you look at those dollars staying from the state centers in the community waivers. At least the first step towards that is something that I know probably my entire career has been talked about, like, well, when those centers close, that money probably just goes to general fund and goes away. To keep all of those appropriations in community ID at a time when we know you were all struggling with staffing and many other issues, that is really a primary battle that we want to continue to keep on the forefront. And we'll certainly need your help to do that. And we will certainly work with others across the state, all stakeholder groups, to make sure that we can rally information, resources, and communication around those issues. So thank you all again. Sorry for the interruption, and wanted to call that out. And again, other questions, and please, if you do have a question, come up to the mic, please, so others can hear you. Thanks, Steve. Steve's going to come up, so we'll give Steve a moment. And I'll remind everyone.
We do have a question online. So this is, Kristen, this is for you. This is from Lynn. Can you please tell me what the number was that Kristen mentioned that we're getting for the CLW waiting list initiative this year?
Same as last year. We're going to get 732 community living waivers that are for the emergency waiting list, 100 consolidated for unanticipated emergencies. That's been pretty typical. The 100 has been for a number of years, except for 2021 pandemic. We had, I think, 50 that year, and that really wasn't enough, particularly during a pandemic, to kind of make sure that all those unanticipated emergencies we were able to get to very quickly. That was a stretch. So pleased that we're back to 100 consolidated.
Just to follow up on that, the fund topic you were talking about in the fiscal code, two things. I appreciate that you're looking at it as a gross number and not a net number. So go for it. I hope you get the gross number. Second issue is it does allow the money to carry over year to year. I think there was language in there, so the fund doesn't have to be
Correct.
used. But I guess I would say the sooner you spend it, the sooner it gets built into the base, and then that perpetual or that annual savings issue goes away, because once you spend it,
It's gone.
then you get it back in the next year once you build it into the base. So that would encourage you to spend it as soon as you get it. I guess that's what I'm saying.
Good point.
All right. No more. Oh,
Patrick
I'll
Barber.
just, hi, good to see you, Kristen, and thanks to everyone from ODP to making it to Cranberry today. So I was made privy that there might be a roadmap, a blue book that needs to come from the budget office to DHS to explain how the budget needs to be spent by ODP. Is that something that still needs to be made available to ODP?
So there's two things, and I'm sure Rick will correct me and jump in here, but so a blue book is published every year
Okay.
based on the governor's executive budget. So governor publishes the budget and it's the first Tuesday in February, and then the blue book comes out 3 weeks later-ish for each department. And that blue book has a lot of detail about each program office, all of the funds where they're being appropriated, all of the contracts. There's a lot of detail in the blue book. So that is based on the governor's budget. So I'm not sure if you're referring to that or the appropriations. This year was a little unusual just in terms of making sure we had a clear understanding of what was passed through appropriations. There were a number of changes in appropriations across DHS. And some of that, we were trying to figure out, there was distinctions in how long they assumed the public health emergency was going on, so what the federal match was. So it took a bit to sort out like what the appropriators were trying to do in terms of the numbers they put down versus what the governor had proposed all the way back in February, any differences in assumptions. So we weren't able to speak with great certainty. We heard all of the initiatives were in there, but I think anybody who looked at it saw there was $78 million more than the governor asked for. And it was, is there something else in there? Or was this just a different assumption about how many weeks were in the budget? Is it prudent pay assumption? We didn't know that level of detail. So there isn't a new document that'll come out with that level of
Okay,
detail.
fair enough. Thank you.
Yeah. Is that?
I think
I
we
looked
can
at Rick
pan to
after
Rick.
I said
Yeah,
all
Rick,
that.
there's a mic there, and if you do want to speak, Mark, we can pan to your leadership here too. Mark.
Batteries dead already.
Hybrid. I don't have a mask on. I'm just gonna grab these.
Rick says he doesn't have really anything more to add.
Well, sorry, Rick, we've gone to all this effort now. You're gonna have to say.
Yeah, no, I was just going to say that the blue book you referenced is a good document for you to go back if you really want a lot of detail. It's there, and essentially, with the exception of the percentage matches, it's accurate. Yeah.
This year's budget was particularly challenging to understand, though. I think the governor's budget, the blue book, what came through the appropriations language, in part because of that change in match and what those assumptions were, but also how the ARPA funding plays into that. It is a little hard to kind of compare apples to apples and make sense of that. I think more so than any other year. It's been, I think, a challenge to kind of sort through what funding is coming from where. But all of our initiatives are there, rate increases are assumed, all of that is good.
So Blue Book always goes to whatever the budget appropriation is, whatever is signed into law.
No, the blue book is based on the governor's executive budget.
Right.
It comes out just weeks after that.
So there's not a revision of the Blue Book. It's just then you go to the appropriation
Yeah.
and exactly what's. And usually, I think it's usually a little more straightforward that you can look at.
It is usually much more straightforward than it was this year.
An emergency health declaration.
I'll talk,
Okay.
I'm going to talk about PHE next year. So,
Okay. Next slide, Craig.
Yeah, so I want to talk a little bit just about pandemic recovery and kind of where we are, and I think how we need to be thinking about this as a system. So, a couple things, and then I'll definitely talk about the PHE, but one of the things I think we all need to be focused on is getting people returning to service. I understand the primary barrier for most people at this point is the workforce issue. But it is not the only issue. We definitely still have individuals and families who are very concerned about safety in terms of returning to different types of services. We recently did a focus group with some self-advocates to talk about any kind of additional tools. You may remember that after the second, I don't even know how many surges we've had. After one of the surges, we had when the governor, we were doing all the reopening, we had put together with self-advocates and families a kind of roadmap to reintegrating and getting re-engaged. That's not particularly, we went back to it, it's a little more detail, and I think the circumstances have changed a lot for individuals and families. That was pre-vaccination. So, different climate for sure. But we still are hearing from a number of self-advocates some real concern about it. Self-advocates who have said, I go out and my staff are great, they mask. So I'm in environments where I'm feeling safe, and then I go out into the world and I'm surrounded by people who aren't masked and I'm terrified. So just helping people kind of work through some of that stuff and figure out, if they're doing activities, how those might look different and how they can get comfortable to be re-engaged. So that's part of it, I think, is some of that work. Some of the other part of it that is not workforce related that I think we've got to be really attending to is we're living with COVID now. We are moving. I don't know when we officially get to say the pandemic is over and now it's just endemic, but I think we need to behave like it is endemic. We are going to be living with COVID. And so what does that mean? That means that ODP isn't going to be telling you, here, you can do this, you can't do this, you can do this. Like we had some very black and white rules early in the pandemic about infection control. And some of the reason that ODP was doing that is because no one else was. Home and community-based services was off the radar in terms of public health systems, in terms of the CDC. It took a while until I think it was, there's something beyond, facility-based care out there. And there are some very vulnerable populations that we haven't published guidelines for. Well, those guidelines have been out there for a while now. And so ODP isn't going to be establishing any more guidelines related to infection control. We can look to federal government, the CDC, in some cases for our facility-based care, Department of Health. But for the most part, the CDC they have been updating the guidance for home and community-based services and for people with disabilities. So what that means is, and it's all guidance. We do not have any requirements. We point you to guidance. And we now live in a world where you as providers, you don't have that sort of black and white, yes, we have to do this, no, we don't have to do that. You have recommendations that you are going to need to apply to the population you serve, to the activities they're engaged in, to the settings they're in and what risks they may pose, and what's going on in the world around you. Are we in low transmission rates or are we in high transmission rates? So you've each got to be thinking about that and develop policy and procedures that make sense for your organization and the population you serve. We have help for that right now. So there are two resources. And many of you have heard me talk about this before. You heard Dr. Trippus talk about this before, but we're not getting a lot of uptake on the resources that are out there. And these are time-limited resources. We have a grant from the Department of Health right now for what is called ID Connect. It's a group of infection preventionists. They are working with our HICUs. They did a series of sessions we asked them to start with CPS. Please start with the day programs because that's an area where the recovery is still really lagging. Varies a lot across the state. We've got, 96% of facilities are open in central region and 45% are open in Southeast. So we've got some really big distinctions just in terms of how much recovery has happened there. And part of it, again, we know staffing is driving most of this, but not all of it. We also have facilities who've said, we've got the staff, but we're still trying to keep distancing. So we're not bringing everybody back, or we have people that can't mask, so we don't want to bring them back. We've got to bring folks back, and we've got to figure out, we can't eliminate risk. We are past that, right? We have got to mitigate risk. We have got to figure out how to do that and think about sort of the holistic needs of the individuals that they're coming to us for help and their families. So please reach out to these resources. You've got the ID Connect at each of the HICUs. They're doing training, they can do technical assistance. We also have the LTC Rise. This is even more time limited, December 31st, I think, is the contract, and it may be renewed. This is the same kind of contract that was the E-Skips and the RIC-Ps and these are contracts that the Department of Health continues to do that have been for outbreak response. Those are in place right now. We can send the resource out to you again. These are health systems. The entire state is covered. You as providers have access to whatever the one where your, what's it called? Your main service location. What's it called? Your headquarters. Okay, I thought it was somewhere technical term. Your headquarters. It's based on your headquarters. You should have gotten information about which one you were assigned to if there was any question about that. As a provider, they will not come and look at a specific facility for you, but they can help you with that training and technical assistance around policies and procedures for your whole agency. If you have an ICF, they will work with you on a facility basis. So they are there for outbreak response, technical assistance. They are also there for helping you think about policies and procedures. For ICFs, they have quality improvement projects that they can come in and assist you with quality improvement projects. So again, we're going to be living with this. I know you all need one more thing to do, like a hole in the head, but we're going to be living with this. The resources are available now. Please take advantage of them while they're available. The ID Connect contract goes through July of 23. So a little bit more time there on that one. But that one definitely will not be renewed. That was time limited grant from health, from CDC. And that I don't anticipate that money will be able to roll over or that we'll get an extension on it. All right, go ahead to the next slide. So the public health emergency was renewed on July 15th. So what this, and there's a couple things to understand about this. It was renewed for 90 days. So the Biden administration has said, we're only going to renew it for 90 days. You can just count that if we're renewing it, it's going to be for 90 days. They have also said, we will give you 60 days warning if we're not going to renew it. Okay. So in 2 weeks, we should know whether or not it will be extended again. If we don't get a notice that it will be ended, then it will be extended. So what the sort of general wisdom is right now from what's coming out of Washington is that it will be extended another 90 days after this one ends in October. So we will still be under a federal public health emergency until the middle of January, which for us means we have an Appendix K through the middle of July. So for us, the couple of really critical things are those enhanced rates for CPS and TRIP that are still in place. It also means that the people who have cap exceptions due to pandemic related reasons will be able to, that will go through that next fiscal year. So we're very pleased with that. We have been anticipating the unwinding of all of this, right? So there have been a number of things that we have that we put into place earlier in the pandemic that we have since changed the operational guidance on. There have been many of those. I want to talk a little bit about Medicaid though. So straight up Medicaid does not have this 6-month extension. That is specific to home and community-based services. So our Medicaid program will have to do that unwinding within that period. For ICFs, that also has to all be done within, there is no unwinding period after the public health emergency ends. The feds they published a state Medicaid director letter. So most of the things that were waived have already been lifted. So I don't think huge impact there from the PHE ending for ICFs. The biggest thing for Medicaid beneficiaries is if people have moved, please make sure that the county assistance office has their address. So the big concern here, because one of the key things about the public health emergency is people couldn't be dropped off of Medicaid. Okay, they could not be dropped. The state is not allowed to drop people from Medicaid, whether or not they still qualify, can't drop them. So there is going to be a massive effort to do redeterminations. Pennsylvania's been doing redeterminations, but there will still have to be this, this full redetermination of everyone, the timing of which I think is still unclear, like how much time we will have to do that between the feds and our General Assembly. But what is critical is that our county assistance offices know where people are, okay? So that we don't lapse in Medicaid enrollment. So please, 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 whatever your role is, if you know individuals have moved, make sure that their address is up to date in the with our county assistance offices. All right, well, why don't I stop there? Questions? I mean, I keep going too. Does everyone follow the PHE timeline? Very good. Okay, I'll keep going. Go ahead to the next slide then, because this is a little bit more that goes with unwinding. So for us, there still is pretty significant sort of unwinding that we need to do, because there are a lot of ways in which we're still using the Appendix K authorities that we had. So we have been, well, and let me back up. We have been through amendments and now through the waiver renewals, trying to make sure that any of the flexibilities that we have been using through Appendix K that we want to continue, that we are continuing, we are putting those into our standard waivers with the feds. So we have kind of diligently been going through and trying to make sure that we are adding those things. We are currently under an extension. Our renewal for our waivers was due July 1. We were not coming to agreement with CMS on a number of things. They issued what's called a request for additional information, which stops the clock on their renewal. So we've been going back and forth with them, mostly around issues related to technology and use of technology. Pennsylvania, like many states during the pandemic, said, you know, we got to do this and we got to do it now, and, you know, let's go. We are trying to incorporate a lot of that into the waivers, and CMS has a lot of questions. They have a lot of questions about how we're assuring privacy, how people are making informed choice. How on earth does this technology help people be more integrated? So we are really working through a number of assurances to the federal government about how we are doing that and what that looks like. We have had to talk with them about why we haven't proposed distinct rates for most services that are being provided remotely. We looked at all of this. We worked and gathered information from providers. The only area that we saw that there was a real distinction in pay was, or in rates, was CPS. So really having to kind of sort through all of this with the federal government, because it is very new, and obviously they've got a lot of states coming at this differently. So we are still back and forth with them. So we requested an extension and have that. So everything in the waivers is based on the June 1 version. If you want the most current waiver, it's June 1 is what we're operating under. And we'll work through this. I'm confident we'll come to a good agreement with them on where we want to see this. But part of the unwinding of those Appendix K authorities for us is getting those pieces into our standard waiver applications. So we are going to have those cap exceptions built in, because the Appendix K is going to end while people are still under the exceptions. You can't take money back. You can't take services back from somebody who's already used them. So there are pieces like that that we're going to have to put in there. We had the DSPs in hospital settings supporting people was back in the June amendment, but this is the renewals are where we are really putting into play all of the use of teleservice, is what we are now calling services delivered using technology. So where we're using the CPS remotely, the employment, the behavior support, Those are now going to be teleservices. That's a term I believe we've agreed to. I'm looking at Jeremy. I think we've come to a conclusion. So if that changes, okay. But I think right now CMS is good with us calling those teleservice delivery of those services. This is, we're pulling remote support out as a separate service definition and working through all of those questions about consent, privacy, integration. And then importantly, and you may have seen, we actually issued a communication a week ago or so to supports coordinators. So we had, back in March or April, we had said, you've got to get out, do face-to-face visits with this priority group of people. These are individuals that are at higher risk. We have concern that nobody has seen them face-to-face. If you haven't seen them face-to-face, get out and see them. And then kind of told SEOs, we are also going to be implementing the new waiver standards related to face-to-face versus remote monitoring. So again, this is, we can still do what we're doing because we're still operating under Appendix K, but we have told supports coordination organizations that as of October 1, they are to follow what will be in the waiver renewals, which is 1 out of the 4. I'm struggling to remember this. 1 out of 4 for the PFDS may be remote, and then with consolidated, 3 of the 6. So half of them can be done remotely, but the others have to be face-to-face. And we have told SEs, and we are telling you, you have to allow SEs that face-to-face opportunity. Yes, there will be negotiation about how to do that safely. Please have those conversations, but you have to allow SEs to do that face-to-face monitoring. And if you are struggling with how to do that safely, please reach out. If you can't get to a resolution through the AE, certainly reach out to our regional offices, and we will work to come to some way to safely do that. Through the pandemic, we have definitely, remote monitoring is great, like it was essential for us. There are things that get missed when people are not in person doing that monitoring. And we are past that. Again, it's endemic. Like we have to get to a place where we are returning to some of these more typical service deliveries. All right, I will stop there again for questions or comments.
Yeah, we encourage you, please, both in the Zoom webinar, here in person. Please step up to the mic if you're here, ask a question. Craig, let us know what's out there. And Kristen, I just want to make an observation and acknowledgement. So I think you've made it pretty clear, or maybe we haven't highlighted it enough. You've really moved forward with the Appendix K application, with the ARPA application from the state. And part of being out front is there's no precedent, and you're doing a lot of advocacy to CMS to kind of push things along, if that sounds accurate to you.
There are a lot of, and let me back. I think we must have been the first state to submit an Appendix K because there were all of the regions from CMS were on the call to discuss our Appendix K. So yes, you are accurate in that. I think we tend to be very out front and aggressive about implementing the policy changes that we see have a lot of benefit. Many of you participated back after, again, I don't remember which surge, after one of the surges, we did an extensive after action review and asked a lot of detailed questions about how people were using specific flexibilities, how many providers thought prudent pay was helpful, that was critical to their operations, how many providers used the fact that we allowed you to work with take other DSPs and allow that training to suffice, all of those different flexibilities we put in place. Because really, as we saw the pandemic was coming, we just literally everything we could think of that we might need, we put in there. So we asked providers like what was helpful, what wasn't. And that's what you're seeing. Like we know from individuals, families, from providers, from AEs, like we heard very clearly that remote services work for some people. 10% of people, 10% of individuals and families, SEs said, yes, please, we want to continue some level of remote service. I want a combination of in-person and remote. There were some that said, I love remote. I don't ever need face-to-face again, please, just with the remote. And then a lot of people who don't use it, doesn't work for them, they don't like it, That was 90% of the population. But 10% of the population, this was a critical way for getting services during the pandemic, and they liked it and they want to continue. We heard from providers that said, you know, for some of the folks who are more medically complex, it's allowed them, when they're experiencing, you know, they can't leave the home, they're ill, they can still engage with their friends. They can still be engaged out in a community activity through the use of remote. I can tell you this one is a struggle with the feds. What do you mean we're going to provide the equivalent of day services in a residential setting? You know you can't do that, right? It's like, this is what we're trying to do here. So they're listening and they're trying to understand that, like how we came to that. But that really is, we got a lot of feedback about how these things worked. Frankly, I think they're also, not only did they work and are they preferred, they are going to be critical solutions to some of the workforce issues that we're having. If you can take out some of that drive time, if you can have somebody supporting multiple people through that teleservice model that would otherwise be, you know, one-to-one, and that DSP, that's the end of their day, you can stretch those resources, right? And still meet the needs of people. So we've been trying to cook all that in, and yes, it is a lot of conversation with the federal government.
Good. I appreciate you going into all that, because I think it's come to light with what you just covered on the slide. And from speaking recently with Jeremy and Lauren as co-chairs of the ODP Tech Task Force, similar issues. And, you know, I guess we sometimes forget that it's not the federal government who leads the way philosophically when it comes to disability issues, and rules are in place. So there's some natural pushback from, you know, what's in statute and things that have been going on traditionally for a long time. So it really comes from people needing services, receiving services, families, and you oftentimes as members are the first people to know that. And as you report it back, it kind of puts you in a position to know, but also want to acknowledge the advocacy that you have to do with CMS. It's become increasingly evident to me that that is something that is an issue in the delays, and that also that it is something that is making them think about, as you just noted with your example, can we approve this? And
Right.
that takes some advocacy.
Right, and they know, like, I mean, this is how it works in government, right? You know, if you approve it here, every other state's going to be, well, hey, yeah, I mean, we'll pull from other states. You know, we see that Maryland just got this approved. How is this different than this? States absolutely do that. So no, they do have to vet these things, because you know, they have regions and they have regional distinctions. But you know, once a state has something in place like that, there are a lot of states looking at the incentive payments we just put into place for the ResHab to life sharing and supported living. There are states very interested in the model of how we did that. So yeah, CMS, they absolutely do process this, and they have to.
Yeah, it's a large bureaucracy to begin with, and then they're setting precedent, is what I'm hearing.
Correct.
So
Correct.
they have to be very cautious about how they do that. Okay, thanks. Craig, do we have any other questions? Any questions from in the room?
Nothing has come in through Q&A or chat right now.
Okay, thanks, Craig. We'll let you go on, Kristen.
All right, yes, I think we can go to the next one. All right, so other sort of pandemic recovery, as you know, Patrick asked me to talk about sort of vision for what's next here. And I think, we're talking a lot about recovery and talking a lot about resilience as well. So in terms of recovery, some of the things, and I'll acknowledge, we had one of the other associations, I had a provider essentially say, it's like you guys are pretending the pandemic is over, like with, we've got QA&I coming now, some of this incident management stuff, health risk screening, the pandemic's not over. It's like, yes, we know the pandemic is absolutely not over. But in terms of recovery, there are a number of things. And I'll say we have some really concerning trends that we are seeing. We have a higher number of provisional licenses and revocations than we've seen. We are seeing a very high number still of, sort of new, high number of Fatal 4 related deaths. Just this week, I think I have seen 3 already that have come through that were all Fatal 5 related. PICA incidents where staff were there and just kind of not, I don't know if complacency, staff that were trained knew the individual and made terrible mistakes in terms of, environmental scans and all of that. So I think, we have, and again, this is understanding the workforce crisis, which means not only do you not have enough people, but the people that are there are working extraordinary long hours. You've got managers who are usually making sure these pieces are all together and the controls are in place, who are working shifts and still trying to do their managerial work. Understood. At the same time, we cannot lose our vigilance on some of these issues. And so you do see continued pressure related to this. So we understand, and we know when we're looking at some of the inspection reports coming through, when we're reviewing these incidents, sometimes it's clearly, it reeks of this is staffing crisis related. Others you can kind of just guess this is the cumulative stressors adding up. So it is, you can't always directly point to it, but it's clearly there. So with all of that understood, we still have to maintain that vigilance. So a couple of things to know, just in terms of looking at different improvement, process improvement and efficiencies related to some of those. We are, in terms of quality assessment and improvement, we've got the self-assessments are out there. One of the things that you're going to see different in this cycle is that historically it's been very black or white. You either meet whatever evidence we're looking for or you don't, and that it's considered non-compliant. We now have some of these areas where it's not binary anymore. You're going to be ranked on a 1 to 5 scale. Are you at best practice? Are you in compliance? Are you in partial compliance? Or are you in non-compliance with those? So you will see us continuing to do that. And I think there were definitely some areas in the past around training where that kind of created an aberration because you had, one of your staff didn't do the CPS training, so you were non-compliant, even though that's 90% really, right? So we've been doing some work to get out of that kind of binary evaluation. The other thing is we are looking at incident management. We're a year in after the bulletin, and we are taking a look at some of the areas that have come out in practice. So we've heard from providers about some of the areas where you feel like there's, some very unnecessary work that we don't have to be doing. We've heard from AEs, from SCs about that system. So there are a couple areas that we're taking a look. We've been in conversation with Temple University about the CI, the Certified Investigator Training, because I think in practice, we're missing some of the principles that are trained in terms of the investigative planning process, in terms of what evidence collection actually has to be. I think there are areas in which we have a lot of inefficiencies because what's being taught now isn't actually what's in practice. So we'll address that. I think we'll probably get some sessions out just to share some of the things that we've noticed where we think there are some efficiencies that you can use that are going to help with that process. The other area that is underway, albeit very slowly and frustratingly so, is we are still planning to replace HCSIS. We are in an active procurement for enterprise case management, which will be the HCSIS replacement. There are a lot of silly things that we do because we have an ancient IT system. So some of the design of enterprise case management, we did a lot of collection of information from AEs, SCs, individuals, families, providers to come up with what we want that new system to look like. And I do think it will also reduce some of the aggravating burdens across the board when we are able to get that up and going. So that at this point, it is still slated for fiscal year 23-24 for for us to have that system. So far, that timeline has not moved, but we are still in an active procurement, so stay tuned. Other recovery. So we have been, and again, you've probably noticed this, is we have re-engaged in some of the initiatives that we were working on pre-pandemic. So we were able to get those incentive payments, all of that structure out. Those are available. We've received one application, we know. So we're hoping we'll see more of those coming through for those incentive payments. We have added children with medical complexities as an eligibility category to the waivers with some additional services that we know those kids need. We have, gotten technology. You just heard a long piece about how we're trying to get that built into the standard waivers so we can continue some of that great work after Appendix K. With employment, I'm really pleased to say that we have surpassed, we're slightly like a 1/10 of a percentage point higher in employment than we were pre-pandemic. So we have recovered. We were at 17% pre-pandemic. We went down to 12, I think. We're back up to 17%. The system has grown since then, so it's actually more people. We've added about 400 additional people, and we're still within that 17%. So that is great news. I will also say, if we can't find people jobs in this climate, we are doing something wrong. We've gotten some pretty exciting applications for the business associate. So we're hopeful that that's going to also produce some additional employment. Staffing shortages, we're not going to be able to get kind of through this recovery without some staffing shortage. That we've approached this as increase in rates, that funding for recruitment, retention, really pushing on that technology as one way to relieve the need for that direct support professional, all of that more intensive one-on-one. We have also continued our expansion of participant direction. Again, another way, if we can get people served by the informal workforce, again, that's one more, gets people service, takes some pressure off of the more traditional service models. So continuing to do that work, trying to still get out all of our training around the ISP staffing ratios. We still, we're struggling to kind of adopt this new model that we put out just pre-pandemic in terms of really evaluating, instead of how many staff does this person need, what are their needs, what can be met by technology, what can be met by environmental modifications, environmental changes, and then what are the staff doing? Not how many of them, but what do they need to do to support somebody? That's the conversation teams need to be having. That's what we want to see in the ISPs. We still have some work to do to get there. But that's definitely another area that I think, without a massive immigration, policy change at the federal government level, we're kind of in this. Like every industry is really struggling here. So we can keep doing, all of this work in terms of trying to make the work in our field more attractive. But we've also got to change the way that we're approaching that work and how we organize around that work. So, I think we've been certainly trying to be supportive in terms of policy, the training and technical assistance that's available to do that. But we've also got to be thinking differently about recruitment and retention. Do we know why people stay, right? Do we know why people leave? Are we thinking about the workforce right now and some of the differences in what people are demanding? There's a demand for some flexibility, right? And that's tough for us in many of our circumstances. How do you kind of meet that need that people are really expecting? We've historically relied on 70% of our workforce that are women. So what can we do to make sure that we are really trying to attract both genders a little more than we historically have? So I think we've got to be thinking differently about what are people who are out there looking for jobs looking for? How do we reach maybe new folks doing that? Is there more of an interest in part-time, which is more difficult, more challenging in terms of training and managing, but does that help? And I know, in talking with a number of you, you've been employing some of those strategies. We've heard providers who have, they've got systems set up so that DSPs are selecting the schedule they want, and then they'll kind of fill in the rest, trying to just give a little more control there and see if that's helpful. So I think there aren't enough of those things that we can't be trying and sharing as a community trying to solve this problem. And then I think you've heard, we're really trying to capitalize as much as possible on what we've learned from the pandemic, and we'll certainly keep doing that. All right, next slide. What are 10:15? How late are we going? 10:30?
10:15.
10:15. Okay.
But you have till 10:30. The 10:15 to 10:30 is break,
Okay.
so you
All
can
right.
have extra time.
So another thing, and this isn't just ODP. I think this is something that we all have to be talking about, and obviously we have a role in this. But a couple of things that I think we need to be really focused on are the continued professionalization of our workforce. So part of the issue here, right, is when you're out advocating, like, what is a DSP? Why is that any different than a personal assistant? Why is that any different than childcare workers? Childcare workers are only making blah, 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 right? These are the arguments you hear. People don't understand what the role is. People don't understand that this is different than a CNA, that the scope of what a DSP does is way bigger than what a CNA does, or a home health aide, or a personal assistant, that it's all of that and more. So part of, I think, where we have to go in terms of really professionalizing our workforce is getting this at the federal government level, getting the standard occupational classification. Within ODP, when we're doing all of the rate work, we're pulling from like positions to figure out what the market wages are, right? And again, it makes that kind of advocacy that much harder because it's unclear what it really is. So I think we've got to do that work, advocating at the federal level for that standard occupational classification. The other thing is we have to have a standardized occupation, right? What does that look like when you have a specific profession, right? CNAs, it's a very specific class. You've got to meet very specific criteria. It's portable. We need to get to that same place. And that's part of the opportunity we have with the ARPA funds, is exploring that. There are states who have just said, this is what we're doing. This is going to be the standardized course that's going to be expected. We've done that with a few things, right? For if you're doing CPS, you've got to do that. I'm trying to think what else. We have a few of them. Anyway, the point is, we want to get to a place, and I think the experience of ARPA will help us do that, to identify what is that standardized credentialing that we all recognize, that we know what that means, that is competency-based, and let's make that portable. Why do we have, we know there's very fluid workforce, right? DSPs working for 2 agencies, at the same time, 3 agencies during the course of a year. Let's not keep retraining people, right? Let's have a standardized way of saying they meet the criteria. So let's get some portability for that training. I think there's also some efficiencies that we can probably get there. We've got a lot of training requirements built into the waivers, built into our regulations. So let's look at getting a more standardized way of doing that and getting some efficiencies. The ARPA gives us a chance to explore this. ODP isn't going to be doing anything without Isaac involvement in this and a significant work group based on the experience of providers who are doing this. And we've received quite a few applications now for different credentialing. So I think we will have that experience through ARPA to really inform some decisions about what that looks like for Pennsylvania going forward. The other and the last piece that I think we need to be thinking about creating is a pipeline and apprenticeships into this work. How do we recruit people into this field and get people who are going to love the work and who are going to stay doing the work. How do we give people a real job preview? So we're not spending a lot of time training people who aren't going to stick around, who aren't going to have a passion for this. So we've got, we have been doing some work with our Office of Income Maintenance, premature to say exactly what that, when or how that's going to roll out, but we've been working with them on a pilot that I think could give us a model for that. And then I know PAR has got 4 different members who are working with high school students to essentially do that same thing, kind of an apprentice type program to recruit high school students. So that again is pretty early in terms of any outcomes. But I think again, we'll have another model of that kind of pipeline and apprenticeship type model. So that I think keeping, looking for those kind of opportunities and building those in is going to be one of the many important ways of kind of getting at this professionalization. All right, and I think I have one more, and then I will definitely stop talking. So I mentioned we've got sort of all this recovery that we need to be thinking about, and then resilience. And so on the resiliency side, some of the areas, and probably the area that we've been most focused on right now, there's a lot of work that's happening around health equity. The pandemic definitely exposed the fact that people with IDD were more vulnerable to COVID, in part because there are a lot of gaps in terms of healthcare. That we have much higher rates of obesity, of diabetes, higher rates than the general population in terms of serious mental illness. So there's definitely a focus on this. CDC has been doing some work around this, and there's been some studies looking at Medicaid data about impacts. So I think this will stay, and I think that is a great thing that can come out of this, is a continued focus on the fact that this is a population that really just, we're not talking about in med schools, that people really have access to care issues and that we have to address. Some of the other things, and this is, we're nowhere near being able to do any of this, but we really want to be looking as part of the work that ODP is doing coming out of this, is taking a look at all of these areas where we clearly need to build resilience. We can't have another situation where, things close down because we've got a virus and suddenly people literally don't have services. That we are 2 years out and we still have people who don't have any services and we can't figure out how to get the services to them. That we have people that can't access the needed mental health or behavioral health services during this time. I think we hopefully have gotten, one of the other good things that came out of this pandemic is we can have DSPs supporting people in hospital settings. And that is the difference for some people between actually getting diagnosis and treatment and not. Some very good pieces that I think in terms of resiliency that we're on the way. But this is something we don't want to lose track of. We learned a lot about where we have major gaps in the public health system in terms of understanding home and community-based services. I mean, and you did this with us. We set up clinics for vaccination. We're not health systems, right? But we did that, and that shouldn't have to happen again. But that had to happen because our system is under the radar. So I think, going forward, these are all the kinds of things that in terms of continuity of operations, in terms of understanding at public health level systems, in terms of emergency management, that our population and home and community-based services are on the radar. Those are things that we're going to have to ensure coming out of this. All right, I'll definitely stop there. So there's time.
You don't have to.
I can,
Yeah,
I can keep talking.
Yeah, we definitely want to allow some time for some questions. So, as you think about coming up to the mic or in the webinar, so if I can backtrack on a couple of things, Kristen, because I know I've spoken to some members, and when you talked about the HCSIS overhaul 23-24, do you think there's anything that can be done in the meantime to sort of streamline process that's in any way helpful. I hear from a lot of people now, providers that, supervisors, managers, CEOs, they're working, delivering services directly. And maybe it even relates to some of the things you talked about with the provisional decertification, some of the compliance issues. I mean, quality in general because of staffing, but also administrative burden, which I think you even used the term and described it that way. We're all aware of that, but particularly now, that just seems like a long time to wait for the implementation.
ECM is just part of it. So
Yeah.
some EIM is different, and that is we are looking. There are a couple of things that we're looking at there that I think may give some efficiencies.
Okay.
The other place that you should be aware, we've heard a lot of concern about HRS, the HRST, and the time it takes to do that. So immediately, so we do think we'll have some efficiencies when we get enterprise case management with HRS. So you don't have to say, repeat all of the new meds you just put in HRS to the supports coordinator, and the supports coordinator doesn't have to plug them in. There is no reason those systems can't talk to each other. So in the background, we're doing some of the work to make that hopefully as it should be efficient. But currently we are also working to assemble a work group. We've been working with inelectability around the assessment requirements under the 6400s and what's in HRS to produce something that I think will create some efficiencies for providers. And we have a work group. Do we have scheduled, assembled? It's soon. August. Okay. So yeah, in August. So we've been working with inelectability in the background about what we can do in terms of their system. And then we'll get feedback from the provider community to put that together. So I think we'll definitely be getting some efficiencies there as well.
Okay, great to hear. Glad to hear about the work group. Similar, I mean, you're aware of everything that we know of and some things that I know members talk about and hear about. So that's appreciated. Any other questions? And I know you just today, I haven't had a chance to really look at it yet. Are you in a place to talk about the supported employment incentive program work group?
Just to say, so we're assembling a lot of work groups right now. When I said we're restarting some of these initiatives, we do have multiple work groups, and they're all short term. I think just very discrete projects, but definitely the associations we've been reaching out for representatives for some of these work groups, and one of them is because we now have this approved model on the residential side, that incentive model, we have now turned to employment to look at whether or not we can't figure out how to do some incentivizing for competitive integrated employment. So we've got some concepts that we've kind of been kicking around that fit with what we think Medicaid would approve, but definitely want some provider input on what that ultimately looks like before we go forward with it.
Great. Well, we'll definitely help you with that best we can. And to backtrack also just the SOC code issue, we've certainly been supportive. I think we've worked with DSP, I know has had a lot of national advocacy, Anchor, I believe, as well. Nevertheless, it almost feels like something that's a bit out of our control, though. And even if it does happen, it's probably a lengthy process. In the meanwhile, there is a DSP workforce and it's out there, just not being recognized nationally. So do you think that the credentialing pieces and the ARPA money might put us in a position to kind of advance that along, even just within the state? And are you considering, once those proposals are in, sort of reporting back on what types of programs people are piloting or where people are going in terms of credentialing programs? Or what are your thoughts on how to next develop that and take
Well,
next steps?
I mean, I'd like to do an advertisement for one of the breakout sessions later today.
Yep.
Yeah, no, Jeremy and I, in the session on credentialing, I think we can talk a little bit about what we've seen in terms of proposals. So yes, I think right now we have proposals. We don't have a ton of learning. There are some providers who, this isn't new, they've been doing this. And so built into their proposal is an expansion. So I think there, we have a little bit of learning in PA about kind of how that works, what it does in terms of retention, how to model it in a way that makes sense. But yes, we can share some of that, and we will most certainly share out as we're getting the applications. We've had how many? Roughly 200 applications that have come in so far.
And deadline is October 31, so you're still open,
Still open.
both on tech and on
Yep.
training,
Both the
credentialing,
tech-
business associate. Yeah.
Yeah.
Okay. Well, thanks, Craig. If you want to just go back to our deck and we'll wrap up the session. We have one question here, Patrick.
So CPS programming prior to the pandemic was a big push by ODP and one that most of us adopted wholeheartedly. It sounds like there's a sea change. Does that seem to be the case, that maybe CPS programming, the way it looks right now, is not going to be the way that day programming services are going to be provided? We're going to do more remote things, maybe more facility-based things. Is that kind of where this is going?
I hope not. I appreciate this question. This is where the workforce crisis hits what we'd like to do, right? I think we have long acknowledged that the model of CPS, getting a couple people out into the community, integrated with whatever activity they're doing in the community, is more staffing intensive than facility based. And right now we have people desperate for anything. We have families desperate for any relief care. We have individuals who are experiencing tremendous loneliness, loss of skills, who they just need services, right? So the reality is, the model that we were making some great progress on back in 2019 and 2020 is a very difficult model right now. And I think we have to have some conversations about, what does that look like? Are there ways that we can do that is less staff intensive? Like, how do we still get to the objective of making sure that people have those opportunities to be integrated in community that is realistic in this current environment? We are not fools. We understand that is very challenging right now. And we've got providers doing it. We do have some providers doing a great job of it, but we definitely have providers that are like, I can barely staff the facility to ratio, and we've got people who are really reliant on it. So I do think, as part of recovery, that's something that we have to talk about. No, we haven't changed our thinking about it. That is still the goal. How we get to that goal, I think we may have to have some conversations about it.
And on the extension of the public health emergency, there's the 30% enhanced rate. Is that 30% still on the previous rates before February? Or is that going to now be 30% on top of the new rates that came out in February?
It is the rates that you're billing now.
Okay.
Yeah, those rates will stay in place until 6 months after the PHE, and then the rates we published in February will go into place.
Okay, fair enough. And then one more question about facility day programming. Is there a square footage density requirement or recommendation that we are having to abide by? Or can facility services be provided at will, essentially without any need for that 6-foot radius that was essentially put into place early in the pandemic?
So this is where I want you to use the IDC, right? Call ID or ID Connect. You still have licensing requirements around square footage and people. You have CDC guidance. You know the population that you support. You know what you can do in terms of the activity schedule, how you are minimizing any risks. You know what you've got in terms of people who can and can't mask. You are going to have to make those decisions.
Sure, and the licensing.
We are not requiring
Okay.
6-foot distancing.
Right.
No,
okay,
that is not an ODP requirement. You have recommendations from CDC.
Sure,
You're going to have to make those judgments.
fair enough. Okay, thank
Yeah.
you.
Thank you. And Craig, we're now to the point where we're at our break. Craig, do you need to say anything about the breakout sessions for those who are participating online today?
For those who will be participating virtually, we are going to put a link in the chat that will allow you to go into a separate room. And then once you get into that room, we'll open the breakout session so that you can self-select what session you want to join. So we'll keep this main room open. And I will post that breakout room in the chat in just a few minutes.
Okay, and what I'll say here is, if you're in the room, we're about to start a break. Craig, if you could just kind of go to our next slides. The breakout sessions are in your programs. Everything we're really showing you is in your programs, and we sent you online a PDF of the program itself. But we need you to clear the room because we're going to turn this main meeting area actually into the breakout sessions A and B. So this will be rooms A and B. We're going to split this in half. So we do need you to kind of clear out and welcome you to go out, visit with our sponsors and exhibitors who we're very grateful for. We're also very grateful to you, our members. So thank you very much. Particular thanks to Kristen and to ODP for coming out today. All you folks that have made the trip out here to spend some time with us, we're very appreciative of your time today. So please help me thank again, Kristen and ODP. Thanks so much.